So the first organism or the parasite is amoebae. So it is a simple unicellular protozoa, and coming to the taxonomy or classification, it comes under the phylum Sarcoidomastigophora, subphylum Sarcodina, superclass Rhizopoda, and order is Amoebida. So the under amoebae, first genus is Entamoeba and species is Histolytica. So if they ask about the classification of Entamoeba Histolytica, you have to write the phylum Sarcomastigophora, subphylum Sarcodina, superclass Rhizopoda, order Amoebida, class Amoebae, genus Entamoeba, species Histolytica. So this will be your classification for Entamoeba Histolytica. So here is classification of amoebae, intestinal amoebae, or next is free living amoebae, and there is list of intestinal amoeba. Except Entamoeba Histolytica, rest are non-pathogenic to human, and the free living amoebae, and they are usually non-pathogenic, and but when comes in contact with the human causes amoebiasis. So all free living are opportunistic pathogen. So this is classification of amoebae.
Entamoeba Histolytica. So it is an intestinal amoebae. So it causes infection in human. That is when human comes in contact with the infectious form of amoeba, that is the cyst of the entamoeba, when it enters and resides in the alimentary canal or the intestine of the human, causing intestinal amoebiasis and extraintestinal amoebiasis. One of the characteristic infection or disease or clinical manifestation of this amoeba is it causes amoebic dysentery. So moving to the history, Losch in 1875 demonstrated the parasite in the dysenteric feces of a patient in Russia, and William Osler in 1890 reported the amoeba in the dysentery feces of a young man who later died with liver abscess. And in 1891 Councilman and Loeffler established the pathogenesis, that is the infection caused by the Entamoeba Histolytica is it causes intestinal and hepatic amoebiasis, and introduced the term amoebic dysentery and amoebic liver abscess. Moving to the morphology of the amoeba, that is Entamoeba Histolytica. So it occurs as three forms in its life cycle. So first is the tropozoid form or the matured form, then the precyst, and the cyst, which is the infective form of the amoeba. So first is the tropozoid. So the size is about 12 to 16 μm, and the average is about 20 μm. So it is larger than the other two forms, and it is actively motile in the fresh dysenteric stool. So this is the morphology, and it has an ectoplasm, endoplasm, uninucleated uninucleus, indigested erythrocytes, and a pseudoporium, which is used for the motility. That is, using this pseudoporium only, they motile in the alimentary canal. So it is smaller, it is larger in case of actively dysenteric patient, and smaller in case of convalescent and carrier patients. So cytoplasm, it has an outer ectoplasm and a transparent inside. Inner endoplasm is finely granular, having a ground glass appearance. It has an uninucleated food vacuoles, erythrocytes, occasionally leukocytes, and the tissue debris. So this is the morphology of the morphology of trophozoite. So this is the morphology of the trophozoite. So the life cycle of the amoeba is from a mature trophozoite forms a precyst, then a cyst. So this maturation of the trophozoite to the cyst is called as encystment stage. So this precyst is between the trophozoite and the cyst. So this usually occurs in the or this encystment stage occurs in the intestinal lumen, not in the tissues or outside the body. So this precyst consists of a large glycogen vacuole and 2 chromatid bars. So this precyst secretes a highly refractile cyst wall around forms a cyst. So next is the cystic stage, that is a maturation of the precyst to a cyst. So the cyst shape is spherical in shape and is about 10 to 20 μm in size. As the cyst matures, so you can see the chromatid bars and the glycogen mass. So as the cyst matures, the glycogen mass and the chromatid bars disappears, and the nucleus undergoes division to form 2 and then 4 nuclei. So 2 nucleus is the binucleated cyst, and 4 nuclei you will call it as a quadrinucleated cyst. So the cyst wall is highly refractile membrane, which makes it highly resistant to gastric juice and unfavorable environmental conditions. So this is the cystic stage, that is the maturation from the precyst to a cyst. So the final cyst is the 4 nucleated quadrinucleated cyst, which is the infective form. So this is the life cycle of Entamoeba histolytica. So how they enter inside, matures and causes infection, and how it is excreted in the feces. So the mode of transmission is by ingestion of the contaminated food or water. So the food or water is contaminated by the infective form of the amoeba, which is the cyst form. So the amoeba enter inside, they go to the alimentary canal, and in the small intestine there takes place the excistation takes place, that is the cyst is converted into daughter amoebae. So the 4 nucleated quadrilateral or metacyst is converted into single nucleated amoebae form. So from the amoebae form it converts into a tropozoidal form, that is the mature or the larger forms which has a pseudopodia, and at this stage so it enters the large intestine, and in the large intestine the tropozoids some invade the epithelial cell of the colon and the ileum and causes colonic ulcers, and some tropozoids undergo encyst stage, that is they undergo a precyst stage, a binucleated stage, and quadrinucleated stage, and becomes a infective cyst, and they are excreted in the feces. So this is how the life cycle of amoeba is completed in the host, and it causes amoebic dysentery. So this is the life cycle. So man is the only host, and infective form is the quadrinucleated cyst or the metacyst, and the cyst can remain viable under moist condition for more than 10 days, and the mode of transmission is the ingestion of the cyst, contaminated food or water, the cyst reaches the cesium or the lower part of the lumen. Excitation takes place. That's where it forms a quadrinucleated amoeba, or then metacystic tropozoids. Some tropozoids inhabit the submucosal layer and causes colonic ulcers. Some develop into precyst and cyst, and they are passed in the feces. So this is the pathogenesis. I told it causes intestinal amoebiasis and extraintestinal amoebiasis, and the incubation period is about 4 days to 4 months. Virulence factors that causes pathogenesis is the motility of the tropozoites. So the tropozoites which produce a pseudopodia, and they move in the colon. So that's one of the virulence factors. And another is by the production of the enzyme histolysine and lectin. So they produce this enzyme, invade the columnar epithelial cells of the colon, and causes amoebic ulcers. So amoebic ulcer is a typical lesion seen in the intestinal amoebiasis. So the ulcers are multiple and confined to the colon. Ulcers appear initially on the mucosa as raised nodules with the pouting edges. They later break down, discharging brownish necrotic material containing large numbers of tropozoites. So this is the explanation of the appearance of the ulcer. So intestinal amoebiasis caused by the virulence factor produced by the amoeba, that is the motility of the tropozoites, and the enzymes produced are histolysine and lectin. So using the enzymes, the tropozoites invade the columnar epithelial cell, causing amoebic ulcer. So it is confined only to the colon and the cesium. So this is the explanation of the typical amoebic ulcer. So this is a continuation of the amoebic ulcer. So amoebic ulcer will look like a nodules and have a brownish discharge, and the shape is like a flask shaped, with the mouth and neck being narrowed and the base being large and rounded. Usually the ulcer extend to the superficial layer and up to the submucous layer. Mostly the invasion doesn't go deeper inside. So in rare cases it causes granulomatous pseudotumoral growth, which may be mistaken by malignant tumor. So this is amoebic ulcers. So amoebic ulcer, nodule shaped, nodules flask shaped, extend up to the submucous layer. In chronic ulcers, clinical features of intestinal amoebiasis, and I told the incubation period is from 4 days to 4 months. That depends on the amount of parasite enters inside. So the onset of the symptoms or the onset of the disease is delayed. That is what they are telling. Prolonged latency, relapse, and intermission. There will be a breakage in the onset of the disease. The disease which we are talking is the amoebic dysentery. The clinical manifestation of intestinal amoebiasis is amoebic dysentery. So this may be confused with bacillary dysentery, but with macroscopic appearance like amount of the stool and the smell of the stool can be differentiated from amoebic dysentery can be differentiated from bacillary dysentery. So amoebic dysentery has a bad foul smelling, and bacillary dysentery is not foul smelling, and the color of the stool is blackish brown in case of amoebic dysentery, and Bacillary dysentery is not dark and it is with blood or red in color. So in the microscopic appearance, you can see the presence of you can see the tropozoites of Entamoeba histolytica in amoebic dysentery stool, which has indigested erythrocytes that we saw in the morphology of the erythrocyte. Next feature is the patient is usually afebrile and non-toxic, but in case of fulminant colitis, which has multiple ulcers in the colon, the patient will be febrile and toxic. So moving to the symptoms, usually not intestinal amoebiasis does not always causes dysentery. So it does not causes dysentery in all cases. So mostly it leads to diarrhea or vague abdominal symptoms. It is called as uncomfort belly or growing abdomen. Chronic involvement of this cesium causes a condition stimulating appendicitis in some patients. So this is the clinical features of intestinal amoebiasis. So things to remember is it causes amoebic dysentery. The onset of the infection is prolonged, and there will be relapse and intermission in the course of the clinical features. And the important clinical feature is the amoebic dysentery. So then you will be talking about the type of the stools and microscopic appearance, that is the confirmation of the tropozoites in the stool. Then you'll talk about intestinal amoebiasis does not always causes dysentery. So mostly it leads to diarrhea and abdominal symptoms. So this is the clinical features of intestinal amoebiasis. So the amoebic infestation or amoebiasis other than intestine is extraintestinal amoebiasis. So the tropozoites present in the intestine, they penetrate the intestinal wall, columnar epithelial cell, enters through the and penetrate the diaphragm and reaches the lungs, then liver and the skin. So various sites where the tropozoites penetrate and causes infection. So this is extraintestinal amoebiasis, and the sites involved in this infection are mentioned here. So first extraintestinal amoebiasis is the hepatic amoebiasis. So this is the amoeba causes liver abscess. This is seen only in case of 5 to 10% of persons with intestinal amoebiasis. So the type of the abscess is thick, dark brown, dark chocolate brown pus seen from the abscess. If untreated abscess, the untreated cases, the parasite penetrates the diaphragm and reaches the lungs, pericardium, stomach, and even the inferior vena cava is penetrated in case of untreated abscess. So it is less common in women and rarely in children under 10 years of age. So this is hepatic amoebiasis. It is the abscess in the liver by the amoeba.
So other sites involved in the infection is the liver, skin, brain, and infection in the not liver, lungs, and infection in the lungs is the pulmonary amoebiasis, and the skin is the cutaneous amoebiasis. So in pulmonary amoebiasis there will be hepatobronchial fistula, and the sputum, color of the sputum will be chocolate brown color. Next is infection in the organs like brain, kidney, spleen. So the parasites from the intestine, they disseminate through blood or lymph and reaches the organ and causes infection. So infection in the brain leads to destruction of the brain tissues and it is fatal. Next is the infection of the skin. This is also from the intestine. The parasite disseminates, reaches the skin, causes lesions. So this is cutaneous amoebiasis. So mostly extraintestinal amoebiasis are rare cases, or untreated or chronic intestinal amoebiasis leads to extraintestinal amoebiasis. So this is a tabulation between amoebic dysentery and bacillary dysentery. So right from clinical manifestation, that is the onset is slow in amoebic and acute or fast in bacillary. Onset of the infection and macroscopic differentiation of the stool. I told the order, color, with that we will differentiate. Next is the microscopic differentiation. So this table contains all type of features used to differentiate amoebic dysentery from bacillary dysentery.
Diagnosis. Specimen will be a stool specimen, and first is the macroscopic examination and differentiate it from bacillary dysentery. So first macroscopic examination is the smell, and amoebic dysentery has a foul smelling, and bacillary dysentery is nil or no foul smelling, and semi-liquid brownish black in color. And intermingled with the blood and mucus. The mucus will be a floggy, so it doesn't adhere to the container. So this is the macroscopic appearance or the first examination once the stool sample enters the laboratory. Next is the microscopic examination, and you do that by saline mount test, and you take a slide, you place a drop of stool sample and you mix it with saline and focus under a microscope. So you have to search for a motile tropozoid with throwing pseudopodia, that is actively motile tropozoid will have pseudopodia, and the tropozoid has ingested RBCs. Next, you search for cyst. Except pre-cyst, you can identify both tropozoid and the cyst in the sample. So cyst has a smooth and thin walled and refractile chromatid bars. To culture the organism, media used for culturing entamoeba is Boeck and Dobrolov media, NIH polygenic media, Craig's medium, Nelson's medium, and Robinson medium. So these are the culture media used for extra sensitive confirmation. Next, serological test used for identifying is the ELISA test, hemagglutination test, and hemagglutination test. So you detect presence of antibodies in the serological test.
So next is the treatment, and I have got a table form in which there is the drug's name and the dosage or the level of the antibiotics and the duration to be taken is given here. And for intestinal amoebiasis, the drugs used are paramomycin and iodophenol, and for liver abscess, amoebic liver abscess, tinidazole and metronidazole are the drug of choice for amoebic infections. Next, amoeba which is frequently found in the stool sample but non-pathogenic, doesn't cause amoebiasis, is entamoeba coli, and it is distributed worldwide, and it is non-pathogenic common cell intestinal amoeba. It is larger than Histolytica, about 20 to 50 mm with sluggish motility, and contains ingested bacteria but no red cells, so they do not invade the epithelial cell and causes abscess. So that's why they are non-pathogenic. So the nucleus is clearly visible in unstained film. So saline preparation, you can identify the parasite. Cyst is larger, 10 to 30 mm in size, with prominent glycogen mass in the early stage. The chromatid bodies are spindle-like and irregular. So the matured cyst has 8 nuclei. In case of Histolytica, the mature cyst or the megacyst has 4 nuclei. In coli is 8 nuclei. The life cycle is the same as Histolytica, except that it remains a lumen common cells without tissue invasion, and it's non-pathogenic. So that's it. Entamoeba coli can be asked as a short note. Entamoeba gingivalis. So this is the first amoeba to be found in human, and it is also worldwide distributed. Only the tropozoid stage is found, no cystic stage and pre-cystic stage. The tropozoid size is about 10 to 20 mm and actively motile. So they produce pseudopodia and multiply. So it is usually seen in the gingival tissues. In case of unhygiene mouth, it is a common cell and it is not considered to cause disease. So it is transmitted by direct oral contact. Gingivalis has been found in bronchial wash and vaginal and cervical smears, where it can be mistaken for Entamoeba histolytica. So this is also morphologically similar to Entamoeba histolytica. So that's it, Entamoeba gingivalis.